Good morning. My name is Julio Delgado. I'm a principal investigator in a number of clinical trials at our institution for patients with chronic lymphocytic leukemia, and also trials for patients who are going to receive CAR T-cell therapy. I've been asked the question, how might CAR T-cells change the treatment landscape for patients with CLL? So my opinion on this topic is basically that there's been an improvement, a clear improvement on the treatment of chronic lymphocytic leukemia. Lots of new drugs approved, BTK inhibitors, BCL-2 inhibitors. So the list is long. So there's no doubt that these patients have improved in their outlook. But despite all these new drugs, there are patients that require something else, that require some extraordinary treatment. That it used to be allogeneic stem cell transplantation, but nowadays, with the advent of CAR T-cell therapy, these patients are being referred for this treatment more and more often. Who are these patients? Well, basically patients who have high risk cytogenetics, who have TP53 aberrations, complex karyotype, and have failed typically BTK and BCL-2 inhibitors. These patients have a poor outlook, have a high risk of transformation, and if that's the case, then all the drugs that we have available, they are pretty useless. So these patients are good candidates for CAR T-cell therapy. Moreover, there are patients who already have transformed disease, Richter's transformation, and these patients clearly do not benefit from all the drugs that are available. They have a very poor outlook, and of course, we would also consider these patients for CAR T-cell therapy. The problem, of course, is that there's no CAR T-cell product approved in the European Union as we speak, and there's no product actually planned to be approved in the near future. So we have to resort to clinical trials, CAR T-cell, commercial, let's say, or industrial CAR T-cell products that are being developed, or as is our case, academic CAR T-cell products. So we, but other institutions as well, are developing our own CAR T-cell product, and we are using this product to treat patients in this situation. So patients with CLL who have high-risk cytogenetics, failing novel agents, or patients with Richter's transformation. And we see good responses, high response rates in terms of CLL. For Richter's, we also see sufficient response rates, although we have also seen some relapses, particularly CD19 negative relapses, because our CAR, as many CARs, target CD19. So I would recommend, if you have a patient, like to refer him for CAR T-cell therapy, find a hospital that has a clinical trial going, and try to refer the patient before the transformation. If unfortunately the patient has transformed, I would still recommend you to refer the patient, because there's a good chance he'll respond to treatment and perhaps have a durable response. But here the prospects are less good. So that's how I see it. I actually see CAR T-cell being the procedure of choice for these high-risk patients, and probably overcome allogeneic stem cell transplantation for that particular purpose. But obviously for patients with high-risk disease, very high-risk disease, not for conventional treatment, because there are many drugs out there for these patients. I don't think there's a need for CAR T-cell treatments in other types of patients. And with that, I'll say thank you for the invitation.